It's nothing to be fearful of. So why are we interested in prostate cancer? Well, it's a big issue. And a couple of years ago, in 2018, prostate cancer overtook breast cancer in terms of number of deaths in patients. So 12,000 deaths per year. That's slowly increasing year on year. We have about 47,000 cases a year diagnosed. And I've given this type of presentation for many years and updated the numbers and figures. And we regard this in terms of cancer work, a big cancer. This is a big cancer. So prostate cancer, breast cancer. In the scheme of it, lung cancer has about 25,000 new cases a year. Skin cancer is the biggest cancer with about 100,000 new cancer cases a year, but not many people die of skin cancer because most of them are quite benign. We think 47,000 new prostate cancer cases a year is a big number. Yeah, I've literally just come from the other room where they're talking about whatever it is, 56,000 new cases of COVID just today. And you realize subsequently how big COVID is compared to our cancer world. I mean, it's just huge when we're seeing these type of numbers we deal with annually happening every day in terms of COVID. And you know, it puts it a little bit in perspective of what we're dealing with here. 12,000 prostate cancer deaths, and what have we seen? You know, so far 65,000 COVID deaths this year. So again, it's quite useful to put that in perspective when it comes to COVID. So in terms of men, prostate cancer is the most common solid organ cancer that we deal with. A few little stats for you. About 1 in 8 men will get prostate cancer in their lifetime, but probably only about 3% of men will actually die of prostate cancer. So there's a lot of prostate cancer that we diagnose and a lot of prostate cancer that goes undiagnosed that is quite indolent. And by that, I mean it is benign, it's slow growing, it's not aggressive, and it's not life-threatening, and may take 30 plus years for it to cause a problem. And when we diagnose that in an 80-year-old man, we can say quite happily that it's not going to affect you in your lifetime. So don't worry about it. We're not going to treat it. So a lot of prostate cancer actually that we pick up, particularly in the more elderly population, men in their 80s and 90s, we don't treat, we just watch. And an estimated 300,000 men are living with prostate cancer at any one time that have been diagnosed, and a lot of that goes untreated. Having said that, that can still cause a lot of stress and anxiety for our men. Being told they've got a cancer, but we're not actually going to treat it. So myself and the team, and we're working on quite a big prostate cancer team, including our cancer nurse specialists who have a fantastic role in terms of supporting and supervising our men and their decision processes, help to reassure our men as best we can. We don't see many men under 50 with prostate cancer. Having said that, just before Christmas, I operated on the youngest man I've ever operated on, which was 39. So we do see occasionally some men in their 40s. It is rare, but it has more of an impact potentially because of the issues on fertility. And some of these younger men still haven't yet had all their family or still want more children. And the whole fertility issue comes in and is a bit more relevant compared to, say, a 75-year-old man that I'm operating on. So majority of the diseases that we pick up and treat are between the ages of around 60 to 80, 60 to 85. It's more prevalent in the Black population. So we go out of our way to maybe screen the Black population a little bit more, and they tend to have a higher grade and more aggressive disease at presentation. Prostate cancer is lower in Asia. in China and Japan have very much a low incidence of prostate cancer. And there would be both genetic and environmental reasons for that. And if we know that if you were to take a Japanese man who has a very low risk of prostate cancer, and you move him to America, and he starts eating an American diet and leading an American lifestyle, within 2 generations, his risk of prostate cancer will be equivalent to a white American male. So yes, geography alters the risk of prostate cancer and where you're from. But we know because of that, there are environmental issues, most of them in your diet, that can affect the risk of prostate cancer. So risk factors for prostate cancer, well, age is the biggest risk factor. As you get older, you're more likely to get prostate cancer. Family history, the genetic component, is historically, I think, in prostate cancer been very poorly understood. It's been better understood and better researched in breast cancer, but that's just related to funding for breast cancer research and more money that goes into that. But slowly over time, the genetics of prostate cancer are being deciphered by our academics, and we get a better understanding year on year on the genetics of prostate cancer. And certainly if you have a first degree relative, that means a father or a brother with prostate cancer, you are significantly more at risk of developing the disease yourself, especially if they were diagnosed at a younger age. And we will target those patients. If you've got a family history of prostate cancer, we will target those patients early on. And we say PSA testing from 45 if you've got a family history. And the other way to look at that is if you've had prostate cancer yourself, you should be talking to brothers or sons and saying from 45 onwards, you should be asking for a PSA test. GPs in this country are not allowed to refuse PSA testing for prostate cancer from 50 onwards if a man goes in and specifically requests it. Obesity, so high body mass index is a risk factor. It seems to be related to cholesterol metabolism. We've talked about the race, and then diet. There is certainly a Western diet puts you more at risk of prostate cancer. So a diet high in fats, high in red meat, cholesterol, dairy products, all these seem to be risk factors that can increase your risk of prostate cancer. Yet if you look at the Asian diet, a diet high in rice, what we call phytoestrogens. So estrogens is the female hormone, and phyto means plants. So plants that contain estrogens. So that's rice, that's green tea. There's some evidence for things like pomegranate juice that can reduce the risk of prostate cancer. But you've just got to think of it as an Asian, Western, Chinese, Japanese type diet is protective against prostate cancer. So these are some of the things that we would recommend. Men ask me, what should I be doing for prostate health? And it's a lot of what doctors are going to recommend for long-term health anyway, which is reduce your body mass index, so lose weight if you can. Low fat diet, low cholesterol diet. Cruciferous vegetables, broccolis, cauliflowers seem to be beneficial. We've talked about the green tea, soy, pomegranates. These are all beneficial. And lycopenes. Lycopenes are in cooked tomatoes. So it is the denatured protein that actually causes the tomato to be red, but it has to be the cooked form. And so tomato soups, tomato ketchup, that type of thing can increase your or decrease your risk of prostate cancer. And lifestyle, exercise, weight loss, sunlight exposure, all seems to helps prevent prostate cancer at long term. But one thing that is not associated with, or doesn't seem to be associated with, is smoking. Smoking obviously causes a lot of cancers. For us in urology, it's a big risk factor for bladder cancer, probably a little bit for kidney cancer as well. but it doesn't seem to increase prostate cancer risk. So how do we pick up prostate cancer? Well, it really goes on. We're lucky in prostate cancer that we have a reasonably effective blood test for prostate cancer called PSA. And that stands for prostate specific antigen. We've heard a lot about antigens this year, but this is an antigen, which is a protein essentially produced specifically by the prostate gland. It's not produced by anything else in the body. And it goes up because of diseases within the prostate. Now, it's not specific to prostate cancer. It will go up because of just normal enlargement of your prostate or infections in your prostate. But it does, of course, go up because of prostate cancer. And that's when it becomes our job as the urologist to really decipher when a man has a raised PSA, the GP will send the patients into us and basically asking the question, do you think this man has prostate cancer? And we will then take the set of investigations further. We will always examine the prostate. So we'll always do a rectal examination because that's quite key. We'll probably repeat the PSA test. We'll ensure that there's no urine infections. And then really our first investigation of choice now is an MRI scan. So the MRI scans, they're quite claustrophobic. They're very tight. It's the sort of big version of the CT scanner. And the last 5 years, the quality of the imaging that we've been getting for prostates have been improving year on year. And this is the type, this bottom right image is the type of image that we will get. And this is a cross section again through your pelvis. This is your hip bones here. You've got the rectum sitting behind, and then outlined here is the prostate. And we get a little gray area in the corner here, and that's a prostate cancer there. And that's why when we do a rectal examination, we can feel these as hard nodules, size of a pea, size of a marble. And you can feel these because majority of prostate cancers, not all, but majority occur in this back area of the prostate. We've talked about that. So once we've done the MRI scan, we will make a decision then on when a patient needs a biopsy. And the biopsy is the definitive test for diagnosing prostate cancer. So we're taking a little bit of tissue away from the prostate. This is heavily, heavily magnified. And this would be a sort of strip of prostate tissue. And we would target that area that we see on the MRI scan. And our targeting is getting better and better and improving. The whole area of prostate diagnostics is a whole research area, a huge area internationally. Because we want to be increasingly accurate more and more that we are picking up disease when we need to pick up the disease and not picking up or worrying patients where we don't need to worry them. And so we do prostate biopsies. It is an invasive test. We do it under local anesthetic. If there was a better test, we would. But this is the key diagnostic test. This is when our pathologist will just say yes or no. Now, if we diagnose prostate cancer, we then obviously have that discussion with our patients and say, yes, look, we've picked up a prostate cancer. And really one of the take-home messages here tonight is that prostate cancer, like all cancers, is not one disease. It's a whole spectrum of diseases, from very mild to very aggressive ones, from pussycats to tigers, and everything in between. So you could have 30 different diseases, and they are all different diseases. They all behave differently. It's not just one disease. And in fact, the term cancer is a pretty much a misnomer, really. It sort of suggests to patients that this is all one disease, and it's a nasty disease to have. Well, as I said, a lot of the prostate cancers we diagnose, the pussycats, are not bad diseases to have. In the higher grade patients, we will say to them, look, we need to probably do a few more tests to make sure that it's not spread any further. And that's what's called staging of cancer. And if prostate cancer is going to spread anywhere, it can go to the lymph nodes. locally in the pelvis. It can spread to the bones, and usually the pelvis or the spine are the key areas that we all look for. And then in very advanced disease, it can go to the lungs or liver or further afield to the brain. But that's slightly more unusual, but it's lymph nodes and bones that we'll look at. Now, there is a small percentage of men, tends to be an older population, that will present to us with advanced disease. They've never had a PSA test done. And they will present with metastatic disease that's already gone to the bones. And traditionally, the only real treatment for that is hormonal treatment to cut off your testosterone production, because prostate cells and prostate cancer grows because of testosterone, your male hormone, and there are drugs that we can give you to cut off that, and the prostate cancer will stop growing. But again, the last 5 years, there's been a revolution in treatments for men with metastatic prostate cancer and advanced prostate cancer, where we can now double the life expectancy compared to literally 5 years ago, and there's a lot more drugs coming out on the market. This area of prostate cancer tends to be managed by our oncologist rather than me as the surgeon, but we work together as a team, and the successes of managing and controlling the disease, advanced prostate cancer, is getting better and better all the time, and patients are doing better and better long term. So let's come on to treatments. So we've diagnosed a man with prostate cancer. We have said to him, look, I think this is a disease that needs treating. It's not the low-grade disease. It is what we call intermediate or higher grade disease. It's confined to the prostate. What are we going to do to attempt to cure? And with prostate cancer, we have a number of different treatment options available to us. And this is what I do day in, day out in clinic with my cancer nurse specialists and my prostate cancer team. I'm counseling patients regarding treatment options. And we will talk to them about surgery to remove the prostate. We will talk about radiotherapy, this is main external beam radiotherapy. It's like X-ray treatment. This is another form, bottom left here, another form of radiotherapy called brachytherapy, which is putting radioactive seeds into the prostate, which slowly emit a radiation dose. Prostate cancer is very sensitive to radiotherapy. So we're very lucky, really, in prostate cancer that we've got a number of treatments that are equally effective. And there isn't really one or the other out of these three that are beneficial over the other in terms of cancer cure rates. It's the side effects of the treatments that are different. So some side effects, some men aren't too bothered about, so they go with the radiotherapy, but others they are bothered about, so they choose surgery, and it's the logistics of the treatments are different. Surgery is just one day, one big operation, job done, hopefully. Whereas radiotherapy is a much longer form of treatment. And with combined hormonal treatment can go on for 3 years in total. These ones on the right, well, active surveillance is for our lower risk, lower grade population. So a lot of men going on active surveillance. And these other ablatherm wires, these, I won't go into that detail, but they're sort of experimental treatments. So I'm going to come on to surgery a little bit, because this is the exciting bit. And this is the bit I've been doing really for 12 years now. I went, as Laurie said, sorry, I went out to Australia back in 2008 and did a robotic fellowship. So fellowship, when we come to the end of our training in the UK, we're going to become a consultant. Some of us go off and do fellowships. So we'll go to world leading centers around the world for a year or so. I ended up being 18 months because my job came to an end in January and it was the middle of summer and it was cricket season and it was sunny in Australia and I didn't want to come home. And we were having a very good life. So I extended it for 6 months. We had 18 months altogether, fantastic time for the family. Kids were very young at that time. And we sort of lived right on the beach. They do work you very hard in Australia. You really do put in the hours, but as a result, you do a lot of surgery, which is what we want to do. So you gain a lot of skills. And I got the job in Canterbury, and I was specifically asked to set up the robotic surgical service. And the chief exec at the time, Stuart Bain, said to me at interview, "Will you set up the surgical service?" And I said, "Yes, if you give me £2 million. And he said, "Not many people ask me for that sort of money straight off." So, but that's what these machines cost. In fact, we got ours for about 1.5 million in the end, but it's that they're expensive machines. This is kind of what it entails, really. This is a sort of a mock-up of an operating theatre with robotic surgery. The robot itself is sort of, it's a keyhole operation at the end of the day. And we put keyholes in the patient's abdomen, and the robot instruments go through those keyholes to the inside. I have nurse, what we call patient side assistant, that will be standing next door to the patient. You can change the instruments and give me sutures and do a bit of retracting. But the surgeon itself is sitting at a console. And this is the first time really ever with surgery that you're not touching your patient. You're not scrubbed up. There's no physical connection. There's only a digital connection between you and the patient. And that's just however long your cables are. And in theatres, they're a few meters long. But you could do this, and it has been done, through an ISDN line between London and New York. And my colleagues up at Guy's organized a MS thesis with a surgeon in New York who did 2 prostate operations with the patients in operating theatres at Guy's, which is incredible, really. And they had to use the military ISDN lines going across the Atlantic because the normal telecommunication lines can slow up a little bit. And the machine was originally designed by a Californian company in conjunction with Stanford University, and it was originally designed for military use. So you could put a robot out in the front line and the surgeons wouldn't have to go near the front line to do the surgery. And that was kind of where it came out of, really, military use. And then it found its home really in prostate cancer surgery. So that's where we're at, really. We've been very successful in our robotic surgery program. Just to give you some numbers, we're about the 5th highest volume center in the country. We do about, busy year would be about 250 robotic prostatectomies. We do use the robot. It's not as specific for prostate cancer. We use the robot for many other operations. We use it for kidney cancer work, bladder cancer work, and some benign reconstructive work as well that we do. And it's not reserved just for urology. It is here at Canterbury, but nationwide, internationally, it can be used for gynae surgery, for colorectal surgery, pediatric surgery. And even our ENT colleagues want to do it for sort of tumors that are down the throat, where they can look in and curve right round and operate on them. And yeah, so we're a high volume center. We've done over 2,000 robotic prostatectomies now. And, you know, we were lucky to get this 12 years ago. Well, 10 years ago for the robot here at Canterbury, and we're now up for renewal. So we're just putting a business plan to upgrade our machine. And but again, to try and get the money in the current times is a little bit tricky. But Susan, our current chief exec, is very supportive. You need a supportive exec team within the trust to back this type of surgery. At the end of the day, and we've got all the costs now, we're lucky now that we've collected good outcome data, and we can show actually it is far more cost effective. For example, we know from our own data that our average time getting patients back to work, or men back to work with open surgery, was about 3 months. And it's now about a month with robotic surgery. So it has a big impact in terms of getting men back to their normal lives, back to their normal health, helping with continence and erectile function, and reducing complications. We've reduced hospital stay. So about 95% will go home the morning after an operation. So this is, you know, major pelvic surgery. And when I was a registrar doing this as open surgery, you know, all patients were in hospital a week, and they'd all go to ITU for 24, 48 hours. They'd all have epidurals. About a third would have blood transfusions. And I can't remember the last time, literally, we transfused a patient. And, you know, they never go to ITU, our men, and pretty much unless we have complications, but that's unusual. But we, you know, 95% walk out of hospital the morning after what is still a major pelvic operation. So it's had a fantastic impact in terms of the surgery that we do for prostate cancer. And as a result, a lot of men are more likely to choose surgery, which is a great treatment for their prostate cancer. We'll touch on COVID a little bit, because this year has been very difficult for our prostate cancer patients. And in May or April time, we decided to really close down the robotic surgery program till about July, when we reopened. So we had a period of not doing any surgery. And as I said, I think tomorrow, from this meeting tomorrow morning, we're going to find we're going to be in the same position for the next couple of months, which is really difficult. But you just don't want to have a major operation and then catch COVID, because we know that the mortality or the death rate with COVID after major surgery is about 20%. It is extremely high. So 1 in 5 men, if you were to catch COVID, or men and women in whatever operation they're having, after a major operation, it can be life-threatening. And we just feel the risk of that currently is just too high. The risk of delaying a prostate cancer operation a couple of months is actually very low, very low. So it doesn't put, because it's such a slow growing disease on the whole, so it doesn't put men at particularly much risk. And quite often men, you know, say to, when I'm looking at dates for surgery, they say, oh, I've got a holiday next month. I say, well, go away on your holiday. Honestly, it's not a problem. And we'll operate when you come back. Because the treatments we are giving to men are to stop the disease causing a problem 10 years, 15 years down the line, not imminently on the whole. When we pick up a prostate cancer that's confined to the prostate, it's not going to be risky for those patients for certainly 5, if not 10 years or longer. But yeah, so the whole management of all our urological cancers has been difficult in COVID currently. But we just have to work with that. We've also had issues around staffing of wards, because a lot of staff have gone off sick and wards have had to close down and theatres have had to close. So trying to run complete services has been very difficult. And so a lot of the surgical specialties, we've had to say, look, we'll just run emergencies only. And we're, of course, trying to not give patients general anaesthetics and keep patients out of hospitals as best we can at the moment, because they can be quite dangerous places. So that's kind of it, really. I think we can stop there. I did have a few